This article, published in Nursing Times, explains the physiology of haemostasis and the clotting factor cascade, coagulopathies that can cause abnormal blood clotting and bleeding, and the condition's causes, risk factors, symptoms, and management. It is read by an automated voice, so some of the pronunciations might not be as you're used to hearing them. It is written by Professor Yamini Nigam and Associate Professor John Knight, both at the School of Health and Social Care, Swansea University. Abstract. Platelets and blood clotting factors are critical for haemostasis, which is the prevention of unwanted blood loss, usually following injury or trauma. Coagulopathies can manifest either as abnormal clotting or abnormal bleeding. Pathologies that cause abnormal clotting include thromboses in arteries or emboli from deep vein thromboses. These can both restrict blood flow to vital organs. A hypercoagulable state such as factor V Leiden can increase the risk of developing such blood clots. Pathologies that can cause abnormal bleeding include haemophilia and von Willebrand disease. Finally, disseminated intravascular coagulation presents as both abnormal blood clotting and abnormal bleeding. It can be a life-threatening complication of many conditions, including sepsis. Haemostasis is the physiological arrest or halting of bleeding, a complex but balanced process that helps stop blood loss. Disruption of this balance can cause bleeding or thrombotic events, which may require clinical intervention. Upon injury, when a blood vessel is damaged, it immediately constricts to reduce blood loss. The platelets, tiny cellular fragments present in blood, come together to form a plug. This plug is then reinforced by the activation of a cascade of clotting factors, culminating in the conversion of the plasma protein fibrinogen into a strong and tough protein, fibrin. This leads to blood coagulation and the creation of a more robust, permanent clot. This Nursing Times article, the third in a series about the pathophysiology of blood, explores coagulation disorders that affect the body's ability to clot blood, manifesting in either abnormal clotting or abnormal bleeding. Platelets and clotting factors. Platelets, thrombocytes, are tiny, irregular, disc-shaped fragments of larger cells called megakaryocytes, which develop in the bone marrow. Platelets circulate in the blood and are also stored in the spleen. Critically important in the process of haemostasis, an individual's platelet count determines their ability to clot blood effectively when needed. A normal platelet count ranges from 150,000 to 40,000 per microliter of blood. A high platelet count of greater than 450,000 platelets per microliter of blood is a condition called thrombocytosis and may predispose people to abnormally formed clots. A low platelet count of less than 150,000 microliters is known as thrombocytopenia and may lead to abnormal bleeding. The platelet plug. In normal conditions, platelets do not stick together or to the walls of healthy blood vessels. However, when a blood vessel is damaged, its inner lining tears, exposing collagen fibers in the tissue beneath. These collagen fibers become covered with a protein called von Willebrand factor, which is released by cells lining the blood vessels. Von Willebrand factor attracts platelets, causing them to stick to the exposed collagen. As the platelets stick, they release three key chemicals that help in clotting: serotonin, adenosine diphosphate, ADP, and thromboxane A2, TXA2. Serotonin helps to stimulate continued vasoconstriction, while ADP and TXA2 attract more platelets to the injury site. This causes membrane changes that render arriving platelets stickier and flatter. These flattened platelets adhere to the platelets already stuck to the collagen. Platelets in this second layer now also degranulate, releasing the three main platelet-derived factors above, thereby attracting even more platelets. The resulting positive feedback ensures that layer upon layer of platelets aggregate, leading to the rapid formation of the platelet plug. This plug can be quite fragile and may be washed away if blood flow in the injured vessel is too vigorous. Therefore, it needs to be stabilized by the fibrin clot. The fibrin clot. To reinforce the platelet plug and stop blood loss, a more robust clot needs to be formed. This relies on the synthesis of a tough, fibrous, rope-like protein called fibrin. Fibrin forms a meshwork around the platelet plug, sealing the injured vessel and trapping blood cells. Fibrin is formed from the plasma protein fibrinogen in a complex series of reactions involving several blood clotting factors, 1 to 13. This can proceed via the extrinsic or intrinsic pathway. The extrinsic pathway is triggered by any external trauma that causes blood to exit from damaged vessels. Clotting factor 7 interacts with tissue factor, which is a large protein found on the surface of many cells and on the cells lining the blood vessels when they are damaged. The complex of tissue factor plus factor 7 triggers the clotting mechanisms within seconds, leading to the formation of activated factor 10. Following this, the extrinsic and intrinsic pathways meet at a shared point called the common pathway. The intrinsic pathway refers to clotting factors that are intrinsic to blood. When blood vessel walls are damaged, collagen fibers are exposed. Contact with collagen fibers activates a protein known as Hagemann factor, factor 12. Over several minutes, a sequence of reactions unfolds, wherein each factor activates the next. Following the common pathway, the last part of coagulation can be summarized in 3 major steps. Both pathways converge with the activation of factor X, an enzyme called prothrombinase. Factor X forms a complex with other factors including factor 5. This complex eventually converts the plasma protein prothrombin into the active enzyme thrombin, factor 2. Thrombin converts fibrinogen into fibrin, factor 1, which forms a permanent clot. Thrombin also activates a fibrin stabilizing factor, factor 13, which strengthens the fibrin strands into a tough clot that stabilizes the platelet plug. This complex process of haemostasis results in the formation of a clot, transforming blood from a free-flowing liquid into a gel-like solid substance that prevents further bleeding and blood loss. Fibrin then acts as scaffolding onto which new tissues grow during the healing process. After the injury is healed, the fibrin clot is dissolved and removed from the body through a process called fibrinolysis. This is essential because if clots remained in place, they could dislodge, travel in the circulation, and get stuck in important blood vessels, impeding blood flow. The fibrinolytic system is constantly in operation, removing unnecessary clots. The key enzyme in this cascade of reactions is plasmin. Tissue plasminogen activator, a protein released from cells lining the blood vessels, converts an inactive plasma protein called plasminogen, produced by the liver, into plasmin. Plasmin splits fibrin and fibrinogen into fragments known as fibrin degradation products, D-dimers, thereby dissolving the clot. The D-dimer blood test is often used to determine whether a patient has recently formed any blood clots. To limit the formation of clots to the site of injury and prevent them from growing too large, the coagulation cascade is regulated by different anticoagulant mechanisms. Two proteins, protein C and protein S, form a complex that inactivates factors 5 and 8. Additionally, a protein called antithrombin 3 directly decreases the production of thrombin and inactivates factor 10. Therefore, any condition that causes an imbalance between thrombogenic, clot-forming, and antithrombogenic, anti-clot-forming mechanisms predisposes an individual to an increased risk of either abnormal bleeding or abnormal blood clot formation. These coagulopathies are conditions that adversely affect the body's normal blood clotting activities. Coagulopathies that can cause abnormal clotting. Thrombosis. Among the most significant life-threatening pathologies, thrombosis is a major blood coagulopathy. Thrombosis is the formation of unwanted thrombi, clots, in blood vessels. If anti-clotting mechanisms fail or are overwhelmed, these thrombi, with constituent platelets and fibrin and accumulating blood cells, can narrow or block a vessel. This can restrict blood supply to the tissues being fed by that particular vessel. This can have serious, even fatal outcomes such as strokes or heart attacks. Emboli, fragments of clots, may also break away and lodge in distant vessels, particularly the lungs or brain. In arterial thrombosis, a thrombus blocks an artery carrying oxygen-rich blood to an organ. In venous thrombosis, it blocks a vein, causing deep vein thrombosis, DVT. Thrombi and emboli can occlude any part of the circulation, but the coronary and cerebral arteries and the deep veins of the calf and pelvis are the most frequently affected. DVTs are clots that develop in the deep venous circulation of an upper or lower limb and can present as pain and swelling in the affected limb. Emboli can migrate to the lungs, causing a pulmonary embolism. The pathophysiology of DVT formation has not been fully elucidated, but the current thinking is that the disturbed flow of blood around venous valves make them uniquely vulnerable to thrombus initiation and formation. This happens through endothelial activation, which allows the adhesion of platelets and leukocytes, contributing to the activation of blood coagulation and trapping blood cells. Risk factors that increase the probability of developing DVTs. They are more likely to occur in people with a history of DVT, who have cancer, are aged greater than 60 years, who are overweight or obese, who are male, with heart failure, with a medical illness, for example, acute infection, who have thrombophilia, with inflammatory disorders such as vasculitis or inflammatory bowel disease, who have varicose veins, who smoke. The risk of DVT is also 5 times higher during pregnancy and 60 times higher during the first 3 months after delivery than the risk for non-pregnant women. Studies have shown how leukocytes contribute to DVT. Within 6 hours of vessel flow being restricted, leukocytes overlay the endothelial surface. 70% of all leukocytes present in a thrombus are neutrophils. The remaining 30% are monocytes. By releasing their internal nuclear content, neutrophils are capable of producing neutrophil extracellular traps, nets. This remarkable defense is a network of extracellular strings of DNA that can bind pathogenic microbes. Platelets can stimulate neutrophils to form netes, and red blood cells also bind to nets with high affinity. This is thought to be a mechanism by which red blood cells are recruited into venous thrombi. Therefore, targeting netes through either degradation or release prevention may provide a new way of treating thrombosis. Hypercoagulable states. A hypercoagulable state, also known as thrombophilia, is a clinical disorder of the blood that increases the risk of developing thromboembolic disease and arterial blood clots. Hypercoagulable states are either primary, inherited, or secondary acquired conditions. There are many inherited hypercoagulable conditions. Factor 5. Leiden is the most common and is more prevalent in those of European descent. Under normal conditions, protein C regulates the coagulation cascade by inhibiting factor 5. In factor 5 Leiden, there is a point mutation in the gene coding for factor 5, which causes resistance to the anticoagulant effects of activated protein C. The factor 5 cannot be inactivated, allowing it to continuously activate clotting factors downstream. This leads to unregulated production of thrombin and an increased risk of clot formation. Acquired hypercoagulable conditions are secondary states caused by conditions or situations that increase the risk of thrombosis, including recent surgery or trauma, medications such as tamoxifen, oral contraceptives, hormone replacement therapy, obesity, pregnancy, prolonged bed rest, immobility, polycythemia, and cancer. Cancer can cause hypercoagulability due to increased production of procoagulant factors and due to malignant cells interacting with the inner lining of blood vessels. Smoking, inflammation, surgery, and trauma can damage blood vessels, repeatedly triggering activation of the coagulation cascade. Inflammatory disorders can also activate the coagulation cascade, reduce natural anticoagulant mechanisms, and impair blood clot removal. It is also believed that a hypercoagulable state occurs in patients with chronic obstructive pulmonary disease, COPD. It appears that this can contribute to an increased incidence of thrombotic events, such as DVTs and venous thromboembolisms, in these patients, thereby increasing the disease-related morbidity and mortality of COPD. This can be explained by hypoxia-induced erythropoiesis, increased red blood cell production, in response to decreased respiratory oxygen levels, as is the case for patients with COPD. Similarly, there is a significantly increased likelihood of thromboembolic events occurring at high altitude, where atmospheric oxygen availability is low. Erythropoiesis requires increased iron transport to the bone marrow, and this occurs with the help of transferrin, a small plasma protein. As well as replenishing iron levels for increased red blood cell production, transferrin promotes blood coagulation by increasing thrombin and factor 12 activities and inhibiting antithrombin. Therefore, an increased need for transferrin and transport of iron may play a role in inducing blood coagulation and hypercoagulability. Coagulopathies that can cause abnormal bleeding. Abnormal bleeding disorders can manifest as a variety of clinical symptoms. These include visible skin indicators such as pinpoint bruises, petechiae, or larger bruises, purpura, that may appear purplish-red on light skin or brownish-black on darker skin. More acute issues, such as uncontrolled bleeding and/or serious. Thrombocytopenia. Thrombocytopenia is a condition that can be either inherited or acquired. In thrombocytopenia, the blood's platelet count is too low. This can occur if the bone marrow cannot make enough platelets or it destroys them. Platelets are stored in the spleen for use when required. In thrombocytopenia, they remain pooled in the spleen and are not released into the blood. This is often due to an enlarged or overactive spleen, which can be caused by conditions such as liver disease, autoimmune disease, or infection. Other factors such as lifestyle habits, for example overconsumption of alcohol, and certain medicines can also slow down the production of platelets. Heparin-induced thrombocytopenia, HIT, can also be a serious complication for patients exposed to the blood anticoagulant heparin. The immune system causes platelets to clot in the presence of heparin, resulting in a drop in platelet levels. Haemophilia. Because the various clotting factors all have vital roles to play in the formation of fibrin clots, A missing or deficient factor will seriously hamper an individual's ability to control blood loss. Haemophilia is the most common inherited clotting disorder. There are two major types, both caused by deficiency in a factor from the intrinsic pathway. Haemophilia A is a deficiency of factor VIII. Haemophilia B, a milder condition, is a deficiency of factor IX. Symptoms of haemophilia include large or deep bruises, unexplained and excessive bleeding from cuts or injuries after surgery or dental work, and nosebleeds without a known cause. Haemophilia can be either inherited or acquired. Inherited haemophilia is caused by a mutation in a gene that provides instructions for making the clotting factor. This mutation can prevent the clotting protein from working properly or cause it to be missing altogether. The mutated gene is located on the X chromosome. Therefore, inherited haemophilia is an X-linked recessive hereditary disorder that typically affects males because they have only one X chromosome. As females have two X chromosomes, they are more likely to be carriers of the mutated gene than to develop inherited haemophilia themselves. However, manifestations of inherited haemophilia can sometimes be seen in carrier females. This is a result of an unfortunate skewed inactivation of the normal, non-carrier X chromosome, causing the dominant manifestation of the disease. This can be severe enough to cause a life-threatening bleed. Acquired haemophilia A, AHA, can occur when the body forms autoantibodies, antibodies that react with self-antigens, against blood clotting factors, most commonly against factor VIII. In 15% of the healthy population, low titers of anti-factor VIII antibodies can be found anyway. These are often asymptomatic in presentation, with no underlying disease causing them. However, AHA has been associated with certain drugs and medications including penicillin and sulfonamides, underlying autoimmune disorders such as rheumatoid arthritis or systemic lupus erythematosus, cancer, infectious diseases, pregnancy. It generally occurs 1 to 4 months postpartum, but cases have been reported up to 1 year after delivery. Patients with AHA may experience acute abnormal bleeding without previous symptoms or family history. The bleeding pattern is usually subcutaneous bleeds, observed in 80% of patients, followed by muscular, gastrointestinal, genitourinary, and retroperitoneal bleeds. Haemophilia can be managed by intravenous administration of concentrates of the missing factor. However, non-factor products have recently been developed that facilitate the coagulation cascade, such as emicizumab, or block the anticoagulant pathway, such as concizumab. Clinical trials of these products are currently ongoing. Von Willebrand disease. Von Willebrand disease is an inherited bleeding disorder characterized by defects in the concentration, structure, or function of von Willebrand factor, a vital molecule in the formation of the platelet plug. It is also a carrier glycoprotein for factor VIII and is synthesized in endothelial cells and megakaryocytes. Low levels of von Willebrand factor are relatively common in the general population. However, not all patients experience clinically significant bleeding issues, so a significant proportion of the patient population goes undiagnosed. Indeed, a von Willebrand factor level of less than 30% indicates von Willebrand disease, so most cases are diagnosed only after investigating severe bleeding problems, such as recurrent and excessive bruising or prolonged bleeding from minor skin trauma, dental extractions, or menstruation. Worldwide, it appears that more women than men are affected by VWD. In a systematic review of literature about von Willebrand disease, Du et al. 2023 found that bleeding was reported in 72 to 94% of patients, with mucocutaneous, gastrointestinal, and oral bleeds being the most common. Life-threatening bleeding involving critical organs was also reported, although this was rare. Von Willebrand factor replacement can be considered in patients with the most severe type of von Willebrand disease, type 3. Vitamin K deficiency. Vitamins K1 and K2 are very important fat-soluble compounds. Sources of vitamin K1 are leafy greens and cruciferous vegetables. Vitamin K2 is found in fermented foods, as well as being synthesized by microbes in the intestine. Many vitamin K-dependent proteins are involved in essential processes, such as bone metabolism, cardiovascular health, and blood clotting. With regards to this last function, vitamin K is essential for the synthesis of prothrombin and clotting factors 2, 7, 9, and 10. Therefore, vitamin K deficiency can contribute to abnormal bleeding, as well as poor bone development, osteoporosis, and increased cardiovascular disease. Vitamin K deficiency is present in 8 to 31% of healthy adults. However, bleeding or hemorrhage typically occurs in people with malabsorption syndromes, such as coeliac disease or inflammatory bowel disease, which can impede vitamin K absorption, or liver disease. Patients receiving medications such as the blood thinner warfarin which interferes with vitamin K metabolism, can also present with vitamin K deficiency and a reduced ability to clot blood if injured. Prolonged use of antibiotics can also disrupt the gut bacteria that synthesize vitamin K. Vitamin K deficiency in newborn babies presents a distinct and critical concern for pediatric healthcare. Since vitamin K cannot cross the placenta efficiently, every neonate is born with low to undetectable concentrations of vitamin K. Newborns with limited vitamin K reserves who do not receive timely intervention are susceptible to developing potentially life-threatening bleeding disorders. Prophylactic treatment for neonates involves administering an intramuscular injection of 0.5 to 1 milligram of vitamin K1 within the first hour of birth. Disseminated intravascular coagulation. Disseminated intravascular coagulation, DIC, is a rare but life-threatening condition. The pathological process is characterized by the widespread activation of the coagulation cascade, resulting in the formation of blood clots in the small blood vessels throughout the body. In a stark and disturbing pathological contradiction, normal blood clotting is compromised, and patients also present with considerable bleeding. This is because the body's clotting factors and platelets become consumed and depleted by the coagulation process, forming abnormal blood clots. The presence of both clotting and bleeding results in a very serious and distressing condition, which can lead to compromised tissue blood flow and ultimately multiple organ damage. DIC usually occurs as a complicating factor of another underlying condition, most commonly in critically ill patients. Causes include sepsis, solid tumors, blood cancers, obstetric complications such as preeclampsia, amniotic fluid embolism, and septic abortion, massive tissue injury following severe trauma or burns, severe allergic or toxic reactions, for example to snake venom, severe infection, especially involving gram-negative endotoxins, toxic molecules produced by gram-negative bacteria. DIC is of critical concern for patients with sepsis. The mortality rate of sepsis-associated DIC is greater than 30%. The prognosis for all patients with DIC depends on how much damage blood clots have caused to the body's tissues. Of those patients who survive, some will live with organ dysfunction or the results of amputation. Conclusion. This article has explained the process of haemostasis, as well as exploring coagulopathies that cause abnormal blood clot formation or abnormal bleeding. The full article, with references, can be found online at nursingtimes.net under the category Haematology. Thank you for listening.